Good morning, everyone, and welcome to our last webinar in our winter webinar series this morning. And I just wanted to welcome everyone and talk about a few logistics. This particular webinar is going to be brought to you in recorded fashion, and our distinguished speakers will be present along the way, and we will take questions in the chat box. And they will try to answer those as we go, but at the end, we will reserve some time for some live questions as well to our speakers. So it is my distinct pleasure to welcome Sonya Lal and James, which I'm going to pronounce James' name wrong, so I'll let him do that. They're going to introduce themselves. James and Sonya are part of our team, of our multidisciplinary team at OCAL. And I remember studying with them as an occupational hygienist, and I'm so happy to have them today. And I remember meeting Sonya for the first time where she described as our occupational hygiene discipline group and as occupational hygienists, this concept of being the Erin Brockovich of occupational health. So they're going to delve into that, and I'm so happy to welcome them today. So without further ado, thank you.
Hello, everyone, and welcome to today's presentation. The title is Using Retrospective Exposure Profiles to Assist Improving Cases of Occupational Disease for Workers' Compensation Claims. I'm James Muccio, and I'm here with Sonya Lau to present to you today.
Thank you, James. Good morning, and thank you all for attending our session. We have a few cases to share with you where we will be giving you a glimpse of how OCAL hygienists crack cases for occupational disease claims in their own unique methodology. This will be evident in viewing how James and myself attempt to solve the disease claims very differently. Hope to keep you intrigued today. Without further delay, let me introduce you to my colleague, James. James has been practicing clinical occupational hygiene with OCAL for the last 13 years. He has 20 years experience in the field. James attained his Master of Science in Occupational and Environmental Health from Wayne State University in Detroit, Michigan. He is a certified industrial hygienist and a Canadian registered safety professional.
Thank you, Sonya. Just so everyone knows, Sonya has been practicing occupational hygiene and health and safety for the last 25 years and has been with the occupational health clinics for 19 of those. Sonya has experience in automotive, furniture, and many other industries all throughout North America, as well as academics. In addition, Sonya is a certified industrial hygienist as well as a Canadian registered safety professional. Giving everyone a little bit of background about OCAL and who we are, what we do. Our website is ohcow.on.ca. We have plenty of resources on our website. For example, we have a heat stress calculator, noise calculator. We try and make the information easy to use and geared towards workers and joint health and safety committees. As with any nonprofit organization, we have a mission, and our mission is to protect workers and their communities from occupational disease, injuries, and illnesses. We strive to address occupational hazards to promote the social, mental, and physical well-being of workers and their families. Now, at each clinic, we have what's called a multidisciplinary team. This includes physicians, nurses, occupational hygienists, such as Sonya and myself, ergonomists, and our client service coordinators. So here's this big map of Ontario, and on the little icons on the map is the location of each clinic in the province. So we have locations in Ottawa, Thunder Bay, Sudbury, Toronto, Hamilton, Sarnia, and Windsor. So one way or another, we cover the whole province from these locations. So just going over how OCAL fits in the health and safety system in Ontario. So OCAL is what's known as a Health and Safety Association, funded under the Prevention section of the Ontario Ministry of Labour. For anyone outside of Ontario, the Ministry of Labour is equivalent to, say, the United States Occupational Health and Safety Association. So the Ministry of Labour is similar in that they enforce the Health and Safety Act. And for purposes of this presentation, the Workplace Safety and Insurance Board is the compensation system in Ontario. And again, OCAL is a nonprofit service, and we provide what we call a unique clinical occupational medical service. And these are the cases we're going to be presenting to you today. And these workers that are seen here at our clinics are referred from healthcare professionals, health and safety committees, unions, advocates, and other workers. So just diving into some of the services we provide. So two main services, the clinical service, again, these are the cases we're presenting to you. These are where we see individual workers who have been denied compensation claims. And we get a lot of questions on how that falls under prevention. And an example of that is, for example, if a worker came in with asthma and it was work-related, we could then go back to the workplace and try and prevent other workers that work there from getting asthma. So that's the relationship there. Other services we provide include workplace evaluations. We answer phone calls for any general inquiries for industrial hygiene, ergonomics, and health and safety. We do a lot of educational type presentations, webinars, toolkits, and more recently, podcasts. And when we're not doing that stuff, we do a little bit of research, and a lot of our staff sits on committees in the communities in which they live. And just going back over to the clinical side, individual patient, again, that's what we're presenting today. And we also do what's called intake clinics. That's where we could see a group of workers from the same workplace or all have similar exposures. An example of this is with the McIntyre powder. It's been in the news a lot lately. But these miners were exposed to aluminum dust before they went down in the mines, and it was thought that they were having some neurological problems as a result of exposure from that. So we did see that as a group of workers at that time. Another one more recent was a rubber workers project where there was various cancers from exposure to carbon black. So we were looking for a trend there of health outcomes. Okay, so diving into the clinical side of our work, again, as I mentioned, these workers have been denied compensation for their occupational disease, and they're referred to OCAL to get our opinion on whether the disease is work-related or not. So if there's evidence to support the claim, we can provide that. And specifically what we're going to be talking about today is the retrospective exposure profile, which is provided by the occupational hygienist. And there is a little bit of guidance out there on this, and it's called the Guideline on Occupational Exposure Reconstruction, and it's published by the American Industrial Hygiene Association. It is kind of the only guideline that's out there for this kind of work, so I'd just like to point it out before we get into the cases.
Thank you, James. This diagram demonstrates the medical and hygiene team interrelationship. The medical team interviews the patient to obtain the work and medical history relevant to their medical assessment. They order any tests which may be required to formulate a new diagnosis or to confirm an existing one. It is critical to note that the OCAL medical team does not treat patients. They are only involved in the diagnosis of the patients and, where possible, establishing work-relatedness of the disease. Only those cases which are complex and which require the involvement of the hygiene discipline are then investigated by the hygienist. In other words, some cases for compensation can be solved solely by the medical team with support of medical tests and research. If the services of hygiene are required, the goal of the hygienist is to establish if there are exposures, and the medical team uses that information as support to establish work-relatedness and submit their medical report to the compensation board or advocate representing the patient. When we speak of reconstructing exposures, the task is to go back in time to when the patient was working and figure out what they were exposed to 20, 30 years ago, depending on the nature of the case and the disease. Hygienists do have a framework to go by when studying cases. Filling in the information is where they are all unique in their strategy. The hygienist has to reconstruct the workplace via information gathering. It's a bit abstract at first. We all use different tools to gather the initial information. Some of us sketch out the workplace layout, place the processes, the equipment within the layout, populate the chemicals utilized, and investigate how those chemicals were manipulated. All this to resurrect the exposures seen. From this point, we can hypothesize the exposures and their pathways and validate this through scientific literature reviews. All this will make sense once we start reviewing the cases. We will go through each of these exposure assessment framework steps in the next few slides. So the first step is to characterize the exposure setting. The primary type of information we are collecting is with regards to the processes, materials used, work practices, and controls, or lack thereof. Job titles alone usually do not give us enough information, as historic processes were often unique to the workplace and to each worker. We will need access to the material safety data sheets relevant to the time period of the patient. Present day SDSs will not be helpful as the formulations change over time. So as we go on with these questions, you will notice that several other branches of questions arise. It can be a lengthy process. I wanted to bring your attention to bystander exposures, as they are often overlooked. These are exposures which occur outside of one's job title, but due to the location in the plant and your vicinity to other processes, you may be exposed to exposures incurred by other jobs. Step 2 of the framework is to identify the exposure pathways. Here we take the knowledge we have of the processes and chemicals used and understand what chemical metamorphosis would have occurred based on how the patient used the products, such as if the process is called for heating, grinding, welding, etc. When products are heated, their chemistry, as we know, changes, and they off-gas decomposition products. By understanding the chemical forms of the agents, we can better understand how the patient may have been exposed, as the usual case is controls were lacking, not maintained, or did not exist. The next step is to quantify or classify the exposure and/or provide professional judgment. So quantifying or classifying the exposure means, can you state that the exposure levels were low, medium, or high? And can you state what the frequency with the exposures were? Were they rare, were they occasional, or were they routine? Either way, you do have to provide a summation through professional judgment of all the findings that you've made. Here you develop a defensible estimate of the exposures which resulted in the occupational disease in question. Let's begin to see how the exposure assessment framework is applied to real-life cases. James will now present the first case.
Thank you, Sonia. So the first case I'm presenting is the case of an aircraft technician. This worker came into our clinic with myelodysplastic syndrome. He was seen by the occupational physician and the occupational hygienist. He had a diagnosis of anemia/myelodysplastic syndrome. It's important to note that all the medical information is summarized and collected by the medical team. And this worker did have a WSIB or compensation claim for myelodysplastic syndrome that was denied. And he was referred by his family physician for our opinion on the work relatedness to aid in the appeal of the claim that was denied. So just what is myelodysplastic syndrome? It's a group of disorders caused by poorly formed blood cells or ones that don't work properly. Specifically, this worker had a decrease in both his red blood cell and white blood cell counts. And some symptoms of myelodysplastic syndrome include fatigue, weakness, bruising, and infections. However, some people can be asymptomatic. Okay, so this worker's claim was denied for a specific reason in that he was unable to show where he was exposed to benzene in his employment history. And one of the things that makes it easier, well, not that much easier, but a little bit, is when claims are denied for a specific reason, we can narrow down our search when going through the worker's occupational history. So how to make the case on this one? We need a detailed occupational history from the worker. We can then perform a literature search. So we search the scientific peer-reviewed literature for similar industries, tasks, and exposures, and then we can apply that to our patient. And then after that, the physician comes up with a final assessment on whether or not they think it's work-related. So this worker's occupational history is that in the 1950s and 60s, he was an aircraft instrument technician. And from the diagram on the top right there, note how the fuel tanks are in the wings of this jet. And our worker's job was to climb into those fuel tanks and clean and change the sensors. Of course, the jet fuel was drained out of those fuel tanks first. However, as you can imagine, there would have been some residual fuel left in those tanks before he went in. This worker had a pretty good memory. He specifically remembered using carbon tetrachloride, trichloroethylene, and methyl ethyl ketone while cleaning those sensors. In addition, we looked up what jet fuel is composed of, and it's made out of kerosene and gasoline. And from working on other cases, we know that there is always a little bit of benzene in gasoline, so that helps us narrow down our search. So moving on to the next part of his work history, 66 to 69, he was an aircraft hydraulic technician. So this more involved the testing, cleaning, and pumps and motors. And again, he specifically remembered using carbon tetrachloride. So the next and last job he had was 1970 to 94. This is where he was an electronics technician working on mail sorting machines. He did note using a lot of solvents, but he didn't remember the names of any of them. And he was mostly degreasing the parts just for general maintenance on those machines when they would break down. Because we can't go back in time and do sampling, what we need to do is search the literature for similar tasks. And we can also look for any epidemiology that might be available to relate myelodysplastic syndrome and benzene exposure, since that's the reason it was denied. So if there are any similar exposures in the literature, we can apply those to our patient. In this case, there was a study from 2000, and they actually did sampling inside some fuel tanks, and they found a benzene concentration of 3 parts per million. Another study I did find that was interesting, a little bit older, but still applicable because that's when our worker was working. So that one from 1956, indicating the benzene content of petroleum solvents could be anywhere from 0.6 to 7%. So quite a range there. Benzene content of solvents does decrease over time as a result of the refining process. So after we come up with some numbers, we can then estimate his average exposure, and we use the parts per million years, and we can then compare that to epidemiology that's out there. However, we also need to consider all the routes of exposure. As I mentioned, that study from 2000, they were air sampling only. However, our worker noted indicate that he was crawling around inside those fuel tanks with the jet fuel still in there. So he would have been dermally exposed. And it's important to note that when doing these retrospective exposures, we assume no PPE was used. It indicates that in that guideline that I talked about in the beginning, because what happens is we don't know if the appropriate PPE was selected, if it was used properly, if the worker was trained on it. So we always assume none was used. However, back in the 50s and 60s, there was not much PPE available at that time anyway. So because I'm a hygienist, I dabble only a little bit in epidemiology. We do get a lot of help from the medical team on this part of it. So specifically, as the hygiene part, we estimate the cumulative benzene exposure in parts per million years. And we get that number by multiplying the average daily exposure by the number of years he was exposed. Now, you also need to consider other tasks and the amount of time specific tasks were carried out. So it makes it a little bit more complicated, but we do have to make some assumptions when doing that. In this specific case, I took that 3 parts per million, multiplied it by 12 years, and my estimate was that he only did it 25% of the time. He wasn't in those tanks all day, every day. It was only part of the day and possibly not every day. So my estimate was 25% of the time. So I came up with an estimate of 9 ppm years. So again, this does not take into consideration dermal uptake, which a lot of studies are showing that when someone is dermally exposed to benzene, they're already overexposed. So from a little chart on the bottom there, I'm not going to dive too deep into the epi, but you can see on the bottom there, someone who is exposed to greater than 2.93 parts per million years is at an increased risk for myelodysplastic syndrome from exposure to benzene. So then our physician comes up with a conclusion saying that there's sufficient evidence to suggest that the development of myelodysplastic syndrome has occurred as a result of his occupational exposures. The medical team does a full medical history, and they didn't identify any non-occupational factors here. For example, he didn't have any other hobbies that would have resulted in any benzene exposure. So at this point, all our reports are submitted to WSIB through a representative of the worker. And so the compensation came back with a conclusion saying that there's sufficient evidence to establish a relationship between the worker's possible exposure to benzene and a development of myelodysplastic syndrome. And just so everyone knows, the timeline for some of these decisions can be years. It does take, hygiene and the medical team sometimes quite some time to dig through all the literature that's out there in the epidemiology to find all the information we need for these cases. So just to list a few of the references for this patient that I thought were important. So this concludes our first case. And at this point, I'm going to pass it over to Sonya to present to you our second case.
Thank you, James. Several references you used in your case were also utilized in our next case, which also involves benzene. The second case we will discuss is that of a manual car wash operator detailer who was diagnosed with multiple myeloma. At first glance, we did not think there would be a link to defend in this case. However, in collecting further information on the patient's work history and more specifically his health history, the findings were very intriguing. But first, what is multiple myeloma? It is a cancerous disease which forms in plasma cells which help fight infection. It can cause cancer cells to accumulate in bone marrows where they crowd out healthy blood cells. Symptoms include fatigue, bone fracture, recurrent infections, and fever, to name a few. This is an example of a case where there was no patient to interview. The patient had passed away. So the patient's advocate and wife brought the case forward to the OCA physician and nurse in 2010. His date of death was 2005. He died at the age of 61. He was of Italian descent. He was a non-smoker, social drinker. He didn't have any hobbies or other factors that would increase his susceptibility to this disease. The medical team took the initial work history for the patient and the following information was obtained. The patient worked at this independently owned business from 1972 to 2001, approximately 29 years. He was a WSIB claimant and he submitted to WSIB for 2 different diseases which he felt were work-related. The first one was for chronic paronychia, and for this the claim was allowed in 2002. Chronic paronychia is an inflammation of the folds of tissue surrounding the nail of a toe or finger, presenting as redness, tenderness, and swelling. It's exhibited in workers exposed to water-containing irritants or alkali and those who are repeatedly exposed to moist environments. The patient was a textbook case of this particular disease. And keep this disease in mind because this is the disease, the vehicle, if you will, that helped with the progression into multiple myeloma. The claim for multiple myeloma, however, at this time was denied in 2002. So the claim for multiple myeloma was denied by the WSIB on the following basis, quote, there was no significant source of benzene exposure or routine exposure to have contributed to the patient's disease of multiple myeloma, end quote. So there was a hygiene report completed by the WSIB team, which we perused. It did not include dermal exposure to benzene. They only looked at inhalation exposure, and the hygiene team concluded that the patient may have been exposed to low-level benzene, but not enough to incur the disease of multiple myeloma. The list above shows the agents WSIB agreed that the patient would have used in his day-to-day work. Solvents, gasoline, benzene, glues and adhesives, to name a few. Our mission was to prove that benzene was present in the solvents utilized and demonstrate the importance of dermal exposure and its significance, as well as look at the inhalation exposure and to demonstrate its significance. So we know the patient didn't wear any personal protective equipment, in particular gloves. His disease of chronic paronychia was proof of that, given the manual work the patient conducted. Our primary focus, thus, was transdermal exposure. As an aside, benzene itself is easily absorbed by the skin and is also a defatting agent. This critical factor was not investigated in the patient file previously, which thus underestimated the overall exposure to benzene and other solvents. The patient's occupational disease of chronic paronychia would have facilitated benzene's ability to be absorbed even more, as well as the other agents. Several researchers have found that benzene is present in several commonly used products such as those listed here. Most of these products were utilized by the patient. MSTSs may not have indicated that benzene was present in these products. it is important to note that it is not a requirement, or it wasn't a requirement, to be listed on the MSDSs if the product is present only in trace amounts. So the first step, if you recall, is to characterize the exposure setting. So we were lucky to have coworkers come forward to help this case. The workplace no longer existed, so there was no fear of job loss by the coworkers. Along with taking their statements, it is always a good idea to help validate even those statements made through interviews, if possible, as an added due diligence measure. In this case, a document prepared and available publicly by the United Steelworkers for car wash operators in 2008 provided a very detailed description of the job tasks for manual car wash operators, as well as typical workplace layouts. The information provided was congruent with the statements made by the coworkers. Because we didn't have any material safety data sheets, another avenue we attempted to explore was contacting the Ministry of Environment to see if the employer had any records of contraventions or fines for this workplace in terms of illegal dumping of chemicals, etc. This was so that we could try to find clues of what types of chemicals may have been involved in the patient's exposures. Unfortunately, there were no fines, thus no clues. More information from the USW document we just spoke about revealed that the patient and workers serviced about 40 to 50 cars per day. A chain and pulley system was in place to pull vehicles along as they were being cleaned, while the car was idling. Surfaces, as you can imagine, were constantly wet from water, grease, and oil residue, just to name a few. The main job duties of the patient included cleaning the vehicle exterior and interior, as well as several other tasks, which we'll discuss in the next slide. With regards to the vehicle exterior, the patient used a rag soaked with gasoline to finesse clean the white wall tires or any other scuffs on the vehicle exterior. The patient would squirt the gasoline from a bottle onto a rag without any gloves. With regards to the reupholstering tasks, the patient was the expert and sole worker for conducting this type of work. He would remove the panels, clean them, and then reapply them with adhesive. This could take several hours to a week for each vehicle. Because of the use of adhesive, the patient would often dip his hands and forearms in pails of gasoline and vigorously rub the adhesive off his arms between tasks. In removing the adhesive in this manner, the absorption of benzene was potentially enhanced as it was being pushed into the skin. The patient also had the duty of cleaning the drainage trap, again without any protective gear, to remove the sludge accumulated from washing the cars. This would normally be completed by a pump truck, but in order to save on cost, the employer had the patient complete this task. The cleaning of the pit could take anywhere between 30 to 45 minutes on average. The sludge would then be collected and shoveled into regular trash. This is probably one of the reasons we may not have been successful in finding any information from the Ministry of Environment in terms of contraventions. The evidence was bagged in regular trash. The second step in the exposure assessment framework is to identify the exposure pathways or demonstrate how the exposures were occurring. So the following key avenues were discussed in great details in this part of the report. We knew the patient was being exposed to benzene by both inhalation and dermal exposures, as well as exposure to the vehicle exhausts. Working in wet environments and the significance of chronic paronychia was discussed. The use of gasoline for job tasks and cleaning. We talked about the drainage pit work as well. And finally, the hours of work, which were about 60 to 70 hours per week. There was a discrepancy with regards to work hours between us and the WSIB. Our interviews showed that the patient worked loads of overtime and several weekends, whereas the WSIB had the patient working only 40 hours per week. So we carried forward with our findings with regards to our interviews from multiple sources and were confident that we could substantiate these claims if need be. Our research didn't reveal anything concrete with regards to a straight-up search of manual car wash operators and use of benzene or gasoline and its link with multiple myeloma for that matter. So we had to modify our search. In a report by Melman in 2004, we found supportive evidence which related to work with petroleum products and multiple myeloma. It led us to look for workers using solvents, exposure to gasoline, engine exhaust, degreasers, and gasoline. So car mechanics were the main surrogate for this patient. we used studies within this industry to help us demonstrate the possible exposure pathways and uptake into the body. Because there were no measurements of actual exposures, we resorted to classifying exposures for this case as a more diligent, conservative approach. Classifying, if you recall, attempts to put exposure in categories and/or frequency of exposure. So categories such as low, medium, or high exposure, and frequencies, rare, intermittent, or routine, for example. We found exposure models which factored in dermal exposure in auto mechanics working with benzene-containing solvents. The slide is a bit intimidating and busy, but we did find 3 models which all factored in surface area of skin available for potential exposure. The first 2 models only considered the hand area for exposure, and the third model by the European Union in 1996 looked at skin exposure inclusive of hands and forearms in automotive workers. Because the patient, as you recall, I'd let you know that the patient dipped his hands and arms into buckets of gasoline, we considered this model with a critical eye. So in this third model, they classified the exposures according to frequency, where one event or one exposure equated to incidental to no exposure, 2 to 10 events or exposures were categorized as intermittent exposures, and greater than 10 events, extensive exposure. So based on what we knew with regards to the patient, that he dealt with 40 to 50 cars per day, 60 to 70 hours per week, this classification was appropriate for this particular patient, extensive exposure. And from the first model, we have an author who James will also talk about, Ignacio, in 2006. In his report, he states that dermal exposure exceeds 10 times the inhalation dose. This is very critical for these types of cases, and we use this argument in this case as well. Our conclusions and evidence demonstrated ways in which the patient was exposed to benzene dermally through the work tasks and solvents used, as well as his inhalation exposures. WSIB had only looked at inhalation exposure. Our summation was that the patient's health condition of chronic paronychia increased his susceptibility to the disease of multiple myeloma due to his exposures to benzene on a routine basis for his employment duration of 29 years for over 60 to 70 hours per week. The claim was won in 2011 based on the clinic's work. It did take a long time to wrap our heads around the research and gather the various exposure modeling to be able to demonstrate the exposures for this patient. After about 96 toxicology papers and other references, in the end, it was worth it. This took about 3 to 4 months, if I recall correctly, to complete. This was a quick turnaround time for the submission and for the results to be known to us for this particular patient. We had a close rapport with the advocate on this case. This usually isn't the case, however. There isn't a hard loop, a loop around, if you will, for folks to let us know the fate of the case. Anyhow, our conclusion was semi-quantitative and qualitative in nature for this case. This concludes case 2, and now I call on James for case number 3.
Thank you, Sonia. Very interesting case. So our case number 3 is the case of an automotive worker. And this worker was referred to our clinic with a diagnosis of myelodysplastic syndrome. So this worker had a 30-year career in the automotive industry, and he was 48 years old at his time of diagnosis. So right away, the medical team noted that it was very uncommon for a 48-year-old to be diagnosed with myelodysplastic syndrome, and he was a non-smoker. So the unit representing this worker was looking for further evidence to support the claim after it was denied from compensation. So diving into this worker's occupational history, he first worked 9 years, from 85 to 94, as a sewer finisher for automotive interiors. He then worked 20 years, 94 to 14, in automotive machining, casting, and engine testing. So when we think about those jobs as hygienists, we start thinking about what exposures are possible. So from this, there's many exposures in those industries and those operations. So silica, benzene, which we know causes myelodysplastic syndrome, formaldehyde, engine exhaust, gasoline, there's oils used, and metalworking fluids, solvents for machine washing parts, doing assembly type work where parts are coated in oil. So looking into the specific tasks he was doing, So it's important to note he was exposed to some oils. These oils were used to lubricate the sewing machine tables. And we know from other cases that benzene is in a residual product in those oils. This company used a product and it was sprayed on those sewing machine tables so that the materials for the automotive interiors could slide easily. This would reduce the force required when pulling and sewing that material. And it was oil-based, so it did contain some benzene. This worker also performed what's called engine hot testing. So when engines were fully assembled, they would be put on a carousel. This would involve the worker manually hooking onto and off of a fuel supply line. And this exposed him to gasoline vapors. And he also noted that when he would do that, some gasoline would end up on his hands and wrists. It was originally reported by the company that this was an enclosed process, which, yeah, I agree, it was enclosed when the engines were running. However, you have the hooking on and off the gas lines where it is then not enclosed. Again, this worker had exposure to silica and formaldehyde from the casting process, metal working fluids from the machining of parts, and, we try and get as many details as we can while we're interviewing the workers. And this worker did end up saying that he did install oil filters onto engines with the torque gun. However, he did this wearing cotton gloves where he would grab the oil filter, dip it in oil, so his gloves would get soaked in the oil. So he did have dermal exposure there as well. Now, benzene was not listed on any safety data sheets for any of these products. But it was there in trace amounts. So it's just not required to be listed. And this worker did work more than a year, 5 days a week, 40 hours. He did work 6 days a week, and he worked all 3 shifts, days, afternoons, and midnights. So once we know all of our information, we then turn to the literature to get support and try to prove the case. So we're looking for benzene. So I don't want to dive too much into the literature. It can be a bit much and a bit overwhelming. So I just tried to summarize a few main points from these, but they're saying benzene is present in trace amounts. Dermal exposure to benzene means you're overexposed. So those are kind of the main points there that we're using for this case as our proof of exposure. Again, moving on, more literature again. Interesting study from 2003. Since our worker was in and around and performing degreasing tank operations, there was a specific study that they did actual air sampling around those types of tanks, and they did find benzene to be present. It looks like 65 parts per billion. It is low, but it is still present, so that gives us more proof of exposure. Again, the next one, benzene is readily absorbed through the skin, which we already know from other studies. And with regards to the gasoline, similar to the jet fuel that I talked about in the first case, this study says even in the year 2000, the percent of benzene in gasoline was anywhere from 1 to 2%. So sometimes we have to somehow assign categories to our workers' exposure. This case, it was a little bit difficult to actually pick various categories as he did so many different tasks and he had so many different jobs. It was just hard to narrow it down. So we kind of just went with proving it was there, proving he breathed it in, proving he had dermal contact, rather than assigning a category. So additional factors here, as I mentioned in other cases, the medical team goes through all of the workers' other information, and they didn't identify any non-occupational factors which would have led to myelodysplastic syndrome. For example, he did not live near a gas station or any high voltage electric towers and no history of pesticide exposure. And the traditional development of myelodysplastic syndrome is usually around the age of 74 years old, and this worker was a non-smoker. So just summarizing this case, it was confirmed through the occupational history and supported by the literature that this worker had benzene exposure for both inhalation and dermal. and really highlighting the fact that he was only 48 years old at the time of diagnosis. The WSIB, or compensation, came back with some conclusions in favor of the worker. So they acknowledged that the worker handled adhesives, degreasers, and other products that would have contained benzene in trace amounts. They specifically noted that when he was hooking up those fuel lines, it would have resulted in some intermittent exposure to gasoline and consequently benzene. So whereas before it was claimed that that was an enclosed space. So you can see that it's in the details that matter when we're interviewing these workers and getting all the information we can. They also noted that even though this worker had intermittent and low level exposure, the worker had clear exposure to benzene. And the worker's exposure to benzene during his employment was a significant contributing factor to myelodysplastic syndrome. So this was a win in this case. So again, I just leave with a few references from this study. Some of them are probably the same from my first case, since I did them both on benzene, just different industries. Okay, so just the last couple of references there, which I thought were important. At this point, I'm going to turn it over to Sonya for our fourth and final case.
Thank you, James. In our final patient case, we look at a senior electrical design engineer and his journey with chronic solvent encephalopathy. CSE is dominated by vague and nonspecific symptoms inclusive of depression, difficulty concentrating and processing information, irritability, impaired memory. The patient and his wife were interviewed in the clinic by the Occupational physician and nurse in 2003. He worked for a company who manufactured conveyor systems between 1996 and 2001. He was unemployed at the time of the interview. He was born in England. He didn't have any hobbies or other factors that would increase his susceptibility to this disease. He was a non-smoker, social drinker, and WSIB claimant, the claim for which CSE was denied. The basis for his claims denial was due to a lack of evidence in his neurologic and screening laboratory medical examinations, which showed no consistent abnormalities. Also, WSIB based their findings on a third-party indoor air quality report, which was completed after the fact, after the employer made several changes to the ventilation system, which based on our findings, this report wasn't comprehensive enough to capture the solvents that needed to be sampled for. We'll get into that in a few slides. We interviewed the patient and co-workers. We also reviewed the patient's self-produced timeline, chronology of events, complete with doctor's visits, symptoms, absences of disciplines from work, etc. It was very comprehensive and helped us with his case profoundly. So we just wanted to put in a plug here, or go off on a tangent for a moment, along the lines of patient timelines and work histories. An OCal podcast related to how you can start collecting information for work histories with a top 10 list of items to be looking for will be launched shortly, so please stay tuned for that. This podcast is to help inform workers today on what note where the information needs to be collected when trying to establish work histories, etc., and what you can start doing today to collect your own in the event you need this information in the future. And I hope you never need this information in the future, but it could be helpful to you or to another coworker. This timeline the patient made on his own is something we speak to in this podcast. The podcast can be found on our website. Look for OPODs. So let's return back to the patient. It is important to mention here that prior to the patient being hired, there were several other employees who were symptomatic and complained that there was an indoor air quality issue within the administrative offices. So for the first 9 months of work, the patient was healthy. Thereafter, symptoms started to appear and intensify, and even after exposure ceased, the symptoms would continue. The symptoms were congruent with those identified in the definition of CSE. The patient had difficulty articulating during regular conversations, multitasking activities were difficult, he had trouble holding objects. Aggression and mood swings are what got him into trouble at work. Unfortunately, they were all solvent related and not related to his own mood. So he became an HR issue versus an employee with legitimate health and safety concerns. As mentioned, the patient's symptoms after 1998 no longer subsided after leaving the workplace. The central nervous system damage was proving to be permanent in this despite cessation of exposure. The NIOSH statement on your screen is congruent with what was happening to the employee. So NIOSH states, damages and effects of exposures of solvents can persist for months to years after removal of the workers from the solvent exposure. Peripheral nerves have the capacity to regenerate, but damage to the central nervous system is more often permanent. So we were able to obtain 2 engineering schematics of the ventilation system, which was extremely helpful in this case. The schematics allowed us to view the ventilation ductwork for the plant and the administrative offices, and how and where the contaminants from the plant were or were not being exhausted out of the plant. We were also given an indoor air quality report, which was spoken about a few slides back, and this was completed in 2001, again, after some changes were made by the employer to the ventilation system. Ironically, at the same time in 2001, the Ministry of Labor was called in anonymously to visit the plant, so we had that report as well. And we reviewed we referenced 31 toxicology research papers for this case and 50 in total in our bibliography. Just to make the point here that these complex cases take a lot of time in terms of research and wrapping our head around finding clues or evidence to support the claims and articulating that in a scientific retrospective hygiene report. This case also took a few months, 3 to 4 months in total. This is a timeline we put together just for ease of reference to the various critical points in the patient's work history. So as we already stated, after 9 months, symptoms started, doctor's visits increased, and days off work increased. Between 96 and 97, the patient found relief when he'd go home from work, but thereafter, the symptoms would no longer cease. At this point, due to his workplace complaints, he was moved to another office from the administrative office area, because this is where he was complaining there were exposures. So he was moved to the plant floor in a mezzanine office above a degreasing tank. Terrible choice for this particular worker, terrible place for this worker to be moved by the employer, and you'll see why in the next few slides. His health conditions deteriorated naturally in this area, and after the changes to the ventilation system were made in 2000, he requested to be moved back into the administrative offices. Symptoms at this point included several outbursts with peers during meetings, uncontrollable anger, and mood swings. So obviously the symptoms were intensifying. In 2001, when the Ministry of Labor had come in after the anonymous complaint, it was found that the mezzanine office in which the worker was placed was being infiltrated with degreasing vapors, as there was no local exhaust ventilation for those vapors. The workplace consisted of spray painting and degreasing operations, just to name a few of the work processes. We did have access to 3 main material safety data sheets, and the commonalities amongst them were the presence of xylene, toluene, and methyl ethyl ketone. There was another MSDS titled Reclaimed Xylene, and we needed to investigate this one a bit further. So reclaimed xylene is xylene that has been recovered from various processes and has been placed in a reusable form for purposes of cleaning, degreasing, etc. And thus it has many impurities in its chemical makeup. As per the supplier whom we contacted, the percentages stated on the MSDS can indeed vary and may contain 100% xylene or 50% MEK or even benzene for that matter in a barrel supplied to a customer. So the contents could vary supply to supply, and thus exposures would follow suit as well if left uncontrolled. There would not be a new MSDS for each barrel of reclaimed xylene that was provided. So if any testing were to be done, or if any conclusions on health were to be made, they would have to consider the contents of the reclaimed xylene and how it was used in the plant to ensure workers' exposures were minimized or understood and workers protected. This was not the case. We looked at 3 main arguments for our case and attempted to demonstrate the exposure pathways. In terms of the ventilation schematics, we found 2 critical sources of exposures. One of the branches of the exhaust ductwork from the paint line were being exhausted solely into the patient's office area when he was in the administrative offices. Why? We don't know. This was simply fact on the schematics the patient brought forward. Secondly, on the rooftop, the makeup air intake for the administrative offices and the plant's exhaust stack were located too close to one another, thus contaminating the makeup air. In terms of the solvent studied, we discussed xylene, toluene, and MEK in our report and how they all insult the same target organ. the central nervous system. We also made mention of benzene as an impurity in these solvents, as you've already seen evidence for in the previous two cases, so we won't be discussing that here, but we also made the argument here as well. In our summation, in the hygiene opinion for this case, we looked very carefully at the third-party hygiene report, as the WSIB did place a lot of weight on this report in their decision-making. And the following was noted. It was found that several operations were not functioning the day of testing, such as the degreasing operations and one of the paint lines were down. There was also no sampling for methyl ethyl ketone in this report, or benzene for that matter. And they did not sample the mezzanine area. Nevertheless, it was made clear that the findings of this report, which were completed after several changes were made by the employer to the ventilation system, were not reflective of the actual exposures which may have occurred for the patient years prior. The ventilation schematics were also referred to in our conclusions. If you recall, the basis of denial for this claim was the lack of physical evidence in lab testing for the patient. It was found through research that psychological tests are more effective to determine exposure to the solvents in this type of case versus looking for physical or neurological examinations showing abnormalities. The OCAL medical team did order psychological testing for the patient, and the test results were in favor of the patient. The case was won based on our joint findings. Although we won the case, the patient did lose his job, did lose his ability to practice as a professional engineer, and his family had broken by this time. So the case was won, but I don't know, did the patient really win? Anyways, this concludes the final case. I will sign off at this time and hope James and I have enlightened you on retrospective exposure studies and our various unique methods of cracking cases. Thank you for being here. James will now conclude.
Thank you, Sonia. So just summarizing things up from this presentation, you can see from the cases we presented today that each case requires a unique approach, and it's in the details that matter, those details that are teased out from interviewing the worker. And you also saw the difference between a qualitative versus quantitative approach and conclusion. And so depending on the amount of data that's available to us, that either enables us to make a quantitative or qualitative assessment. And finally, hygiene is defined as the art and science of assessing workplace exposures. So you could see how each hygienist could approach each case with their own methods based on their own experience, literature, and available information. So finally, thank you everyone for attending. Please feel free to email Sonia and I at the email addresses provided with any questions you may have. So thank you for attending, and we hope you enjoyed the presentation, and we hope to present more interesting cases to you in the future. Please be sure to fill out the surveys that come after this presentation, and let us know if there's any other topics you would like us to present to you in the future. And last but not least, please follow us on either Facebook, LinkedIn, Twitter, or YouTube. And thank you for listening.
Well, thank you, Sonia and James. Sorry, I thought you were jumping in to take some questions. So I just did want to invite people to write a question in the chat window and or put up your hand or unmute yourself should you like to ask a question. We did place a number of resources for you in the chat window, including the referral information for any potential cases you may be interested in having our services, along with our prevention efforts through Prevent Off Disease, if you'd like to hear, and is your cancer work related, as well as the podcast that Sonia was referring to. So anything else, Sonia and James, that you would like to bring to our attention from the chat window?
Just wondering if there's any brave participants who would like to let us know whether they enjoyed the cases that we shared, or if there's something else that they would like to hear in the future from us. Any constructive criticism, anything?
It's William here. I think overall was a very well put together presentation. My question was basically in regards to making a claim. Is there any statute of limitation?
William, thanks for being here. What do you mean exactly by limitation? I want to understand the question.
From the period of exposure, Do you have to file a claim if you realize you've been exposed to some kind of hazard in the workplace within a certain a certain time period, or?
So the folks that like we discussed today, some of them didn't know. So sometimes what happens is folks, share information through word of mouth with other folks, and they're in the retiree stage. So I would say no, there isn't like a time period. Once you've come to know that, okay, I have an occupational disease, I'm suffering, and I feel it is related to my work, that's when the ball can start rolling. So in that regard, I don't feel there is a time period that you have to fulfill or be in. Once you figure that I'm sick today and I'm like 70 years old, but I feel my disease is work related, you can start the process then.
Very good. Thank you.
James here. I do see a comment in the chat about asbestos, and yes, we have lots of examples with asbestos. That's definitely something we can do.
This is George Friedman Jimenez from Bellevue NYU Occupational Medicine Clinic in New York. We're part of the New York State Occupational Health Clinic Network. This was a really outstanding presentation. I really enjoyed it. This is one of the critical parts of occupational medicine, is establishing exposure. And I was wondering if you all at OCal would be interested in collaborating with us in the clinic network in New York in setting up some sort of a repository of literature. Sometimes it's hard to find articles on these exposure and disease relations. For example, the latency period. It's difficult to estimate epidemiologically, and sometimes there are articles that do a reasonable job. And it would be very useful if we had sort of a library of articles with brief annotations of what the article shows, a critical review, on things like the latency period or the causation relationship between a chemical and a disease. And we would be interested in talking with you about setting something up like this, because we reinvent the wheel all the time. We do a whole literature search for another patient that we may have done a few years ago, find some of the same articles, maybe miss one or two, and it would be good to organize that in a way. So if any of you would be interested in talking, I would love to chat with you about collaborating on setting up some sort of a library. So for example, you would have myelodysplastic syndrome and benzene and articles on each. If you find an article on the latency period, that would be, maybe difficult to find because old literature is hard to find and search for. So that's my question, if we could maybe collaborate on this.
George, that's, and Sonia and James, if you're okay, I can take a first crack.
Sure.
Responding. So George, yes, we are interested in any collaboration, and wonderful to hear. I sat on the board with the Association for Occupational and Environmental Clinics and would like to bring it to that level as well. So absolutely, I've left my email address to contact. I lead out the occupational hygiene discipline group and a couple of the clinics as the director there, and then sit on the board for the AOEC. So it would be great. To discuss all collaboration. Thanks.
Great. AOEC would be an excellent mechanism for this,
yeah,
I
think so. Okay, we're a quiet group on a rainy day, depending on where you're at. I just really want to take a second to thank again Sonya and James, and talking about tertiary prevention. So we don't often get a chance to discuss what we're doing on a day-to-day basis here in our clinical work on our patient file cases. We are often then showing you what we would like to do with secondary and primary prevention to prevent clients from coming to us at this stage of the game as well. But it's really important knowledge to share and excellent work that they do. So just really big thanks to Sonya and James for sharing with us today. Have a great afternoon, or I guess rest of your morning and afternoon, everyone.